Okay, we are live and you can go ahead.
Hey, nice job, Frank. Thank you. Great. Okay. So let's start. I'm glad everyone could make it tonight and to be on Zoom again. I'm sure that's a little more convenient for a lot of you, but it was kind of sweet to all be together in July. So I hope we'll have that opportunity, later this winter, maybe when things settle down a little bit. So that would be nice. So I think right away we should start with approval of the minutes. Can I have a motion, Larry?
I move that we approve the minutes.
Okay, and a second, Tom. Any corrections or thoughts on any feedback on them? The one thing I noticed under the DD subcommittee report, I think it said that I reported on that, but I think it was either Elise or Sheila.
I think it was Sheila.
Okay.
Yeah.
All right, I'll make that.
Okay. So with that correction, all in favor of accepting the minutes from July?
Aye.
Okay, great, thank you. Any privilege of the floor comments?
Oh, actually,
Larry?
I just want to really acknowledge the IPD. They rescued someone who was on top of the Seneca Street garage. And the article that appeared in the Ithaca Voice, it was basically the press release from the Ithaca City Police Department. And I thought it was very well written, talked about, and the person who was quoted, whose name I can't recall now, talked about the relationship that they have with the mental health department and with other first responders, and also talked about the importance of having those services. So I think that was a great way to talk about what could have been an unfortunate incident. And I think it's the way we want people to hear about what's happening when the police get summoned to a crisis, to a mental health crisis. So I think it made the community look good because we are good at what we do. So I really appreciate it.
Oh, thank you.
It was several weeks ago.
Mm-hmm.
So if people wanted to look it up, I'm sure it's still somewhere on the Ithaca Voices website. You just might have to search for it.
Mm-hmm. That was great. I saw that too, and to just have the public be more aware of how we collaborate with between mental health and the police and the difference it can make.
Yeah, but to have the IPD say that, as opposed to Frank saying that, I thought was, not that Frank's not important, but I think for the police to say that they really think this is an important service is a good thing.
Mm-hmm. Great. Any other comments or announcements? All right, we can move on with our agenda then. Yeah, so just for my part, I just wanted to acknowledge that we're back here on Zoom, and I think the legal part of this is that we are allowed not to meet in person. I think Frank said until June, if that was what seemed.
January.
Oh, January? Okay.
Yeah, January 15th is where it currently runs to.
Okay, so we'll have that period of time that we'll continue to meet on Zoom, and see what January brings. But I know in some ways this is definitely more convenient for a lot of folks and cuts out some travel time. But I also know that it can be a little trying to meet on Zoom. So I appreciate your flexibility about this. So that's pretty much what I had for tonight. So we could go right into the commissioner's report and get an update there.
Sure. Thanks, Mary. Don't have a lot tonight. I can give a little bit of a COVID update. Obviously, things have changed a bit since the last time you all met. Our numbers went up pretty significantly, started with summer travel towards the end of July, and then really picked up when the students returned. Things are starting to settle back down a little bit. We're, roughly about 250 active cases after having been close to 500. What we've really, tried to start focusing the community on is looking away from necessarily case counts every day and really focusing on the severity of illness, mainly what hospitalizations and the need for that level of care. We've vaccinated a lot of people. We've started to re-engage the community. I think we were talking about this the last time that we were together, that we would likely see cases in the fall as we started to do things we hadn't done with less restrictions, and that included higher ed and summer vacations. And now we're with K through 12 and seeing how that's gonna go. But what we're really focused on is, how people are reacting to the disease in our community. And so far, even with record case numbers, our hospitalizations have remained low. And I know that can be challenging. It's a challenging narrative to kind of grab onto, because we've spent the last year plus trying to eliminate all cases of COVID. And we're still working at that. We're still doing huge amounts of work on case investigations and contact tracing. And they're really where we're focused. Those public health measures are in our high-risk populations. So healthcare settings, hospital, nursing homes, and with our children who are in school that are unvaccinated. And so, as you know, there's definitely more restrictions in place in those settings. And then, of course, last week, the president announced some new initiatives around vaccine mandates that he's going to be implementing across the country through employment. So there's a lot of moving pieces going on. I think, here locally, we've certainly seen cases go up, but the good news is our hospitalizations have not matched that. And we've really been able to keep the severity of illness down. And that's mostly attributable to the vaccination status here. We're still talking to our partners, mental health, substance use, developmental disabilities, around any vaccination needs that they might have. Vaccines are pretty readily available in the community. So I think at this point, they're all feeling like they've either had the opportunity or know where they could access vaccine if they have interested clients or staff. So that work all will continue, and we'll see how the rest of the fall goes for us. As far as the department, things are still moving along. Harmony's going to talk about a couple of things later in the agenda that we think are going to be of interest to you all. And then we've had some staffing changes. We brought on some new social workers. We've had an internal promotion of one of our social workers to a senior social worker. We're doing some shifting around with our mobile crisis team and where that's going to live in the department. It somehow started in the forensics unit. And it was really Harmony and the leadership in the department coming forward and saying, with us trying to, change our approach to public safety, does it really make sense for our mobile crisis team to live in our forensics unit? And it doesn't. So we're moving it, and it's going to be part of our adults our adult team within the clinic and under the leadership of that Emily Cool, who eventually will be taking that over from Susan as she transitions into her new role. So lots of exciting stuff going on there. I think ultimately it all will be good news when we get settled with things. But I just wanted you to know the goings ons in the department. The staff are doing well, still under trying situations, right? As you can imagine, as case numbers went up, there was a lot of concern about providing in-person service. And, we've been trying to communicate with staff about all the safety measures that we have in place, our universal precautions, and that we really have to make ourselves available for those that need in-person services, and that we're going to do everything we can to make it as safe as possible for them, as well as for the clients that we're serving. And I think that's all that I really have. I'm happy to answer any questions anybody might have.
Paula?
I was just wondering what our vaccination rate was looking like for school age who are eligible.
Yeah, it's running about the same as our general population. So between high 60s to mid 70% range. It's lower than we might want it to be honest with you. I had hoped that the kids would have, taken it upon themselves to get vaccinated at a bit higher rate. But we continue to do vaccine clinics, including some in the schools in the last few weeks, to try to make it as easily accessible as possible.
Larry, did you have a question?
At the last meeting, there was a conversation about, and perhaps Harmony is getting to it. We'll talk about it, but there was conversation about peer advocates for or in pros, and the subcommittee was going to talk. I wonder if there's been any discussion among department personnel or people who are at pros or with MHA informally, and what the status is of anybody else's thinking.
Harmony, did you want to jump in?
Sure, thanks, Larry. So we did discuss the possibility of having a peer support specialist in our PROS program with an over target request, and there was some discussion about who would be the most appropriate to provide that service. And so, Larry, I believe you and I also talked with Mary about the most appropriate place for that, because last time, you can see from our minutes, we talked about having that in the mental health subcommittee, except I think Khaki and Elise also had some questions about that. So talk with Mary, and we're hoping to put a little work group together, potentially with you, Mary, Elise, Khaki, anyone else who might be interested. I've talked with Heather at PROS. She's going to be a part of that. And I think, Larry, you had suggested that we have mental health associates come and talk about their peer services. Talk with Mary about that a bit. And it sounded like maybe we can get a couple of other agencies to talk about their peer services. I think that could inform our process so that we can decide how best that should look. And we should get that scheduled hopefully within the next few weeks. So if you are interested in being in that work group, please reach out to me or to Mary. And I think we can have people come and bring us some information, and then the community service board members can have a discussion about what they think might be the best option for us to move forward with that.
We also adjusted the OTR so that the funding is in a professional services line rather than in staff and fringe lines. So that gives us some flexibility in the approach that we might want to take after the work group has a chance to meet and staff gets a chance to think through what the plan might look like. Just a budget update. So the county administrator tomorrow will be presenting her budget to the legislature. I don't want to get too far ahead of her other than to say all of the OTRs that we submitted are recommended for funding in one form or another. Much of it is one-time funding meant to be covered by ARPA funds as the legislature goes through that process simultaneously with the budget. But the good news is the things that came forward were able to be included in the county administrator's budget. So once she presents that tomorrow, then the official budget documents will be out and we can share more details about all of that.
Any other questions for Frank? I just wanted to mention that Salimar has joined us. She is, I think you'll all remember that we recommended her joining our board. I don't know if it was July. I'm pretty sure it was July. And that's in process right now, but we're really happy she could join us as a guest tonight. So thanks for coming. All right. Harmony, did you want to add anything to Frank's report, or do you want to just go into your incident report?
Well, I have one thing to add, and that was we talked last time about doing a little something for recognition for board members. And Mary actually helped a lot with that process, which, okay, she's a board member. I'm not so sure she was supposed to be putting so much work into it, but want you to know there are these little bags here for every board member. If you want to stop by and pick up your special bag to recognize you, we were hoping to do a little something in person. So this created a little bit of a glitch, but there is something special for everyone that is a board member for all that you do, a little thank you and an appreciation for you. And if you're not able, if you don't regularly come downtown, if it's going to be a hardship for you to get here for your bag, let us know and we'll figure something out, because we have staff who live all over and I'm sure someone would be happy to drop off your bag for you. But it's hard to be a board member and come out all the time and, you know, spend your evenings like this. And many of you dedicate a lot of time by leading a subcommittee and spending a lot of time in work groups. So just wanted to say thank you for doing all that you've done for a long time. And then next month, there's going to be someone coming talking about from the conference of local mental hygiene directors who's going to come and talk about why is there a board, what are your duties? And I think that will be kind of informative discussion to learn more about that, especially for people who are new. And Salimar, we have a bag here for you as well. Okay. We're not forgetting you. So that's that, and I can go right into the discussion, the next agenda item on the annual report, if you want me to.
Yeah, sounds good.
Okay. So the annual incident review report, this is for 2020, so we're a little bit behind. And then the hope would be that you would get the 2021 report probably sometime in January, February, and that would just become a regular agenda item for you every year. So I am going to share my screen with you.
She says confidently.
Can you see my screen?
No, we can't.
Oh,
Oh, there we go.
I needed to click it a few more times. Okay. And now, there it goes. I was gonna say, oh, it wants to give me an advertisement to turn on subtitles, which I don't think I want to do, but I don't know how to make it go away. Okay. Oop. So the first slide just said that this is our incident review committee. Let me see if I can go back.
Can you go back to it?
Yes, it got blocked by some advertisement there on my screen, and then I clicked too soon. So this is our 2020. It's really just the 2020 year, and then you'll get more on 2021 next time in the beginning of the year. But there's some things, there's sort of a crossover, so there's a little bit of information here. But basically, the Incident Review Committee has a co-chair with Jana Thibodeau. She is the quality director, along with Susan Spicer, who's the clinical director. And as you can see, there are a number of different people who are on that committee, including Mary Hutchins, who represents the board on the committee. There's also a client and family member representative on the board. The committee is mandated by both the Office of Mental Health and by the New York State Justice Center to review incidents. And they meet monthly when there is an incident to review. By law, they have to meet at least every 90 days. The purpose of the committee is really to respond to evaluate our responses to incidents and look for ways to manage them better. How can we make improvements in our systems and our processes over time to reduce future incidents? So in 2020, there were 20 reportable incidents. I don't want to go into much depth about those incidents, given such a small number, and it may be identifiable information, but there were 20 of those incidents. And the one trend the committee really noted in 2020 was an increase in polydrug and opioid-related incidents. So a lot of the things that they have done in response to that started a couple of years before that, and then there's been some enhancement, a real focus on people with co-occurring mental health and substance use disorders so that we can better address those needs with clients. So the first action step was the implementation of the Opioid Overdose Prevention Program, the OOPP. That program started in 2019, and what that means is that the clinic became a certified site to distribute Narcan kits to any and provide that education to people. So if someone walks in today at the clinic and says they would like to have a Narcan kit, somebody can give them that education right at that time and give them the kit right at that time. And they were just recertified this August for that program. And this is a kind of a hard graph, I think, to see, but you'll see there's a lot of orange and then a little blue. And what that means is clients may have started in the clinic clear back in 1988, probably not very many of those, right? All the way up to 2021. So the goal of this action step is to complete a substance use disorder assessment for everybody at the time of their intake. So as you can see, that's still a work in progress. It's something that is regularly evaluated by the quality department with the clinic and with the pros department, but we're trying to make sure everyone, when they're admitted at the time of the intake, has an assessment completed. So you can see if someone maybe got an intake in 2013 or something, it's harder to kind of go back. It's easier to change the process going forward. This isn't perfect, but we're continuing to work on improving it so that we make sure that we're recognizing when people have a substance use disorder, and that if they do, that it's being addressed in their treatment plan. The third action step is to improve collaboration with our OASIS providers. So this actually started, so this is where it's a kind of interesting crossover. I don't know what we're going to show you in 2021 because what we noticed was in some of our reviews that maybe a person is getting their substance use treatment from one of our OASIS providers, but they're getting their mental health treatment from us. So we can provide some of that care, but if a person's like in drug court, they're going to be mandated to an OASIS provider, but they might be getting mental health treatment with us. How can we improve our collaboration among those providers? So we have designed a multi-party release. We've had it reviewed by a number of our staff in our different programs, like our wellness court, our drug court, other providers of different services we provide. We've had it reviewed by some of our OASIS partners. We confirmed with the Office of Mental Health that we could make a multi-party release, and it's now the final draft version is with the county attorney for review, who's looking at the privacy language, the HIPAA language in particular. And what this will do is we can have this signed. It'll be a two-way multi-party release, so we can talk to different people that a client might be getting services from, specifically around substance use is where we started with, but if they have other service providers, it makes it easier for us to provide collaborative care. Because they can just sign one release and it will work for both parties, and it could be more than one agency that we can use that tool for. is communication is king, right? When you're trying to treat people. So the next action step is better support clients with co-occurring mental health and substance use disorders by becoming more familiar with a tool called the locator. So this is a training our clinical staff are going to receive. It's a voluntary training, except for some departments like our mobile crisis team. Everybody will get this training, the mobile crisis team. And then it's clinicians who have an interest in it to learn more about it. But the locator is a tool that's used by OASIS programs to determine level of care. So if we're seeing a client in our program who has a co-occurring substance use disorder, and maybe they need to go into an intensive outpatient program, or maybe they could benefit from a residential or detox setting, we would be able to do that evaluation ourselves and make that determination. Because we know our OASIS partners are busy, and we want to make sure that we're giving good information to our clients, and it will make us better at understanding the levels of care in the OASIS world and providing better treatment to our clients. This is a very colorful chart that's got a lot of action going on. So I will try my best to explain it to you. One of the things that was realized was that some clients have significantly higher needs and greater risks than other clients. So creating a high risk list leads to better care, because you'll see on that top blue line, it's sort of hovering around. I mean, max was maybe 95 people in June of 2020, and now it's around about 65 people in August of 2021. Out of almost 2,000 people, these people are the clients we're serving that have the greatest risks and needs. So a person might be getting discharged from the hospital, or they might have had a suicide attempt recently. So they are at a higher risk, and they have a regular weekly meeting to review their treatment needs. And you can see some of the assessments that they're also continuously getting evaluation for. So those lines kind of move around the place, but basically if a person's on the high risk list, when's their next appointment? Did they get a safety plan completed? Have they had their substance use disorders assessment completed? All of those things are monitored, and the clinicians get weekly information about anyone on the high risk list. So we're making sure we're giving special attention to the people that have the greatest needs. And along with that, when you think about high risk lists, somebody who's discharged from the hospital, how do we improve our communication with the local Cayuga Medical Center? So we want to make sure that we are getting good information when they're discharged from the hospital. So we have somebody who sits on an intake meeting that coordinates services. Our quality person sits on a meeting with the hospital to make sure that we know about people getting discharged from the hospital that are being sent to us for outpatient care. We've updated our release of information process. So before COVID, it was a paper heavy, Post-it note kind of process. Not the most efficient way to do make sure we have all the releases and that we're communicating effectively with the hospital. So since that time, that workflow has been significantly improved. And if clients are getting discharged from the hospital, we want to make sure they're getting put on that high risk list. So communication, again, very, very important. We want to make sure we're talking with the hospital that if people are getting discharged from there, they're getting into our clinic as soon as possible, and that people are aware of their heightened needs. Action step number 7 is providing the vicarious trauma support for clinicians. So we know that the clinical work is incredibly challenging. It's been incredibly challenging during COVID, and it can lead to burnout. And so most recently, so we're really cognizant of the need to help support our clinicians who are doing very intensive work. We just had a creative self-care training for clinicians. It was a fun arts and crafts it was an art therapist led it. And the whole purpose of it was not to learn a new skill as a clinician, but was to learn about your own self-care and taking care of yourself so that you can take care of others, right? Like put your oxygen mask on you first in the airplane if there's a crisis before taking care of the person next to you. There's the soft landing. I believe you've heard of that before, and that's really a support group for people that they're still offering, that's offered on 9 a.m. on every other Friday. And again, that high risk list. So if there are people on your caseload that are keeping you up at night that you're really concerned with, every week you're meeting with a multidisciplinary team to talk about those clients who have high risk that you're probably most concerned about. You're getting a lot of support from other therapists, from the psychiatric department, from your supervisor, and you're getting a lot of information from Quality all the time to help you make good clinical decisions and not feel alone in that really challenging work. All of that makes it a better environment for our clinical staff. So action step, I tell you, we're almost there. You guys are doing good. We're almost there. Collaboration between our mobile crisis team and law enforcement. And Larry, it was great for you to bring up. That was a really nice article that talked about the importance of communication and collaborating, especially in high risk situations like that. So we want to make sure we have increased partnership between law enforcement and the mobile crisis team. Our mobile crisis team provided de-escalation training to the Ithaca Police Department this spring. Rich Shaw, who's our dual diagnosis coordinator, provided mental health first aid just recently to the Sheriff's Department. We're working on a debriefing protocol with the Sheriff's Department and Ithaca Police Department. And so when we have a situation and we're saying, wow, it just felt funny, I didn't understand why you responded the way you did, or this just didn't seem to go so smoothly. Let's have a time where we can get together on a monthly basis and just process those events so that we learn each other's systems better. These are systems issues, not people issues, and we got to understand each other's work better, respect each other's work so that we can make improvements. So that's, we're planning to start that in October. And the crisis intervention team, law enforcement training was through a grant that was submitted by the Sheriff's Department. And we worked closely with that grant that was successfully received. And that training is going to just start next week, September 20th through the 24th. The final day of that training includes a panel with NAMI representatives and Mental Health Association. We'll have representatives at that panel for law enforcement officers to learn about what it's like as an individual with mental illness or a parent or loved one of someone with mental illness when you're a family member or you go into crisis, and creates more empathy and is usually the part of the training that is most well received by the officers. There will also be a component of that training that I will be doing along with Beth Harrington of Suicide Prevention and Crisis Services on all the local services that are available in the community. So law enforcement knows, these specially trained officers will know specifically about other services in our community. Our local NAMI is making a small card that CIT trained officers will be able to give out to individuals or family members. And it's just going to have a couple of names, numbers, links on it for people to go for basic kinds of services that they're most likely going to need. It's nice to have something handed to you concretely that can say, here are some places that you might want to reach out to for support, so that their generosity is really appreciated in that collaborative effort for training. And one of the needs, or well, actually two needs on one slide that were identified in 2020 was the need for sober and detox housing. That's an area where we don't really have enough support. So sometimes people who are really struggling with an addiction end up living in an environment where a lot of people around them are actively using substances, and it's a recipe. It's a recipe for failure. You need to be in a place where you're feeling supported in your recovery, and that can be really challenging. So that was an identified need. And as we all know, there's no easy solution to that particular problem, but it's certainly something that continues to be on our radar. The other need that was identified was the need for more community outreach workers. So Family and Children's Services has the community outreach workers that are limited to the city of Ithaca. The Office of Mental Health just reached out like a week maybe a week and a half ago, their new forensics center that they created in the midst of COVID with a grant. And they said you have 2 weeks to write a grant. So there wasn't a lot of time to get a lot of input on that. But I reached out to Family and Children's Service and Hugo Medical Center, and we talked about an expansion of the community outreach workers for a rural outreach worker program. And that if we get it, it will expand the program to 2 community outreach workers and a coordinator and a van. And they will be able to go to places outside of the city, including the hospital, where they can work with anyone who may have gotten sent to the hospital through our mobile crisis team or through law enforcement, to help wrap services around them through this coordinator's position, and also help create a crisis services plan with them. So if they ever need crisis support, again, we have an individualized plan if they're willing to share that with the CIT trained officers, the mobile crisis team, so other people, so that people can better support them. Right now, the Mental Health Association does a plan for people who are discharged from the hospital like that, but these are people who are not admitted to the hospital, yet they have significant needs. So they have case management needs and they have crisis support needs. And the van will also have basic material supplies in it that they will be able to give out to people. They'll have tablets so they can link people with services. So keep your fingers crossed, and we hope that gets funded, and that will meet one of the needs that was identified through our incident review process. And I'm sure most people would agree that are familiar with the needs in the community, that having more people that can just go out and immediately respond to people is really helpful. Finally, what's our shining star? What was the program identified through the review process that we're super proud of and has done shown a lot of remarkable success? And that's our school satellite model. It's been shown to be really positive for youth. What we know is when children are getting their counseling services in school with appropriate release, we're able to really help coordinate and communicate effectively and be responsive to children and their families right in the school setting. Where's our opportunities for improvement? Well, we need to engage more children and families and youth and expand the program whenever possible. We're hoping to expand into another school site later this year. We're in the process of filling out all the paperwork on that. And I can tell you the sites we're in now. We're in Dryden Elementary, Middle, and High. We're in Enfield Elementary School. We're in Ithaca High School. We're in Groton Elementary, Middle, and High. And we're in Newfield Elementary, Middle, and High School, and Trumansburg Elementary, Middle, and High School. We have somebody that's working 1 or 2 days a week in those schools. And it makes a significant difference. It's much easier for children. They're not missing a lot of time and travel to and from school to come to our clinic. It really helps parents who might have transportation barriers to getting their children into care. And also, we need to be cognizant not everybody wants to have their child get treatment in school. And we also offer services in the clinic. So it's offering people choice is still very important. And we want to make sure people have their preferences addressed and be person-centered in that regard. The advent of telemental health has been really helpful too. So let's say a child missed a day of school, but they could potentially do a virtual session with their therapist who's at school, that school site that day. So, or they come to the clinic and they can do it right from their home if that's the best option for them. So that is our summary of our incident review committee. I don't know if people have any questions, thoughts.
Larry, you have a question?
So, 2 questions about the incident review. One is, if a board member wanted to see the statistical breakdown, how would one go about seeing that? Because we usually have gotten the statistical breakdown of like how many deaths, how many. So I feel like it would be useful for me to know that. But the other is, keep in mind, I mean, I know that Tammy and her colleague have probably pushed the boundaries about where they can go in the city. But the city, the catchment area for the outreach workers in the city is pretty prescribed as well. So if we get this grant, we might be able to push the boundaries out a little. Just a thought.
My apologies for not giving you more of the detail. I wasn't sure how detailed it was. And since I also know it's live streamed now and it hasn't been in the past, I could send that information in an email. Would that be sufficient?
Yeah. I'm particularly just interested since we were talking about the number of, or we were talking about people who had overdose emergencies. The one issue I was interested to ask about was if something happens like that in the building or in one of our programs, are the staff who respond, do they get some kind of debrief?
Yes, we do debrief staff on different kinds of incidents, even if they didn't rise to the level of a reportable incident that would go through the committee. Whenever we learn of anything that's very stressful for staff, somebody immediately is reaching out to them. Typically, it's going to be like the supervisor or several people might even reach out just to check in with somebody, and then we can see how formal that needs to be. Some people would say, I'm fine, I don't need more than that. But we're trying to be really sensitive to, even situations that are not going to rise to that level, but certainly for something that serious, yes. Because they do really impact people. And as Mary can attest, at the in the committee meetings, the clinician assigned to the case will come and talk about their treatment and different things that they've done. And I think it's a nice way, almost kind of cathartic, because there can be, here's all the things I tried. And while sometimes you identify, well, here's some things we can learn for the future, there's always, it seems, that piece of, and here's all the really good work that you did do as well, because things can go badly, even when it seems like, you did all the things that you thought, but you can sometimes find a systems way to improve things, but help that and support that clinician even through that process, I think. I don't know if you would have more to add to that, Mary.
Yeah, no, I have found it to be a nice blend of support for the clinician, but also being open to think about what else could have happened. So I think people find it a useful process. And just as a member of that team, I've continually been impressed by the thoughtfulness of all the clinical work and the openness to feedback. It's been impressive.
So I actually had I had two other questions, if I can ask them quickly. One is, do we have that same kind of relationship with other hospitals about knowing when people are being admitted or discharged? And the other is, it occurred to me that if what we're trying to do when people are discharged is make their discharge more successful, because we've all heard things that we don't like, I wonder if it would be possible to do a follow-up with the client and ask them, so how did this seem? Did you get did you get the housing? Did you get the support you needed? Were you discharged at 5 o'clock in the afternoon on a Sunday? I mean, all that stuff that we want to try to avoid.
So I'm writing down, it would be important to see about survey data and as a follow-up on services.
Yeah, just to make sure that actually being more involved in the process there is actually having the impact that we want it to have.
Mhm. I will take that back to quality. So a good idea. And as far as other hospitals, we also work closely with Greater Binghamton and Elmira Psych Center. So those would be the two ones traditionally that we would be working with.
Harmony, I'm aware that we're doing some, there's some community activity focused on reducing incidents of suicide. Does our data reflect any trends that would be useful? I don't know if you have that information or.
I don't have trend data. I only have it for the year. I will say from the Suicide Prevention Coalition, when we were looking at numbers, they seem to be sort of about the same each year. There wasn't like a big increase, but there wasn't a big decrease either. They seem to be kind of flat over I think we looked over the last 5 years.
Okay.
But I can get that.
Larry, I'm remembering some data sheet we've gotten in the past that compares a number of years for different categories. Is that what you're thinking would be helpful? Okay.
Okay.
And I'll apologize, Harmony, for my note in the bylaws memo that we hadn't been getting those reports. So I was going to orally say, though I'm sure that's going to change with Harmony. So there you go.
I will work with Jana on getting you, if you have a copy of something that you used to get that you liked. So I know like a format or a style, but you're saying basically whatever the incidents are, our incidents really are around, Kaki asked me a whole bunch of legal, like which part of the laws, and then I tried to write back, and you probably have another question for me. I saw that you sent an email. I'll try and look it up and get back to you on that. But for the Incident Review Committee, there are both Justice Center and Office of Mental Health combined, and then separate categories just for Office of Mental Health. And understanding that a lot of these categories are created for every kind of program possible. So they're all blended, like what a hospital might have is very different than the ones an outpatient clinic has. So ours really sort of fall into the ones you're going to get reports on are going to be deaths, even if it's a death for natural causes, and suicide attempts. Those are like the two categories really that our information falls into. The other ones would be, would be around abuse of a client or something like that. They're those kinds of categories, which hopefully, knock on wood, will never have a category like that. Any other questions in regard?
Well, I just thinking, while we're talking about that committee, let me just ask the regs that talk about the Incident Review Committee. Speaks of members, plural, of the governing body of the mental health provider. So I'm just wondering why we only have one member, and our bylaws talk about at least 2 members of the board, and also a physician, which is not required by the law. So that's going to be one of the things that Sheila and Mary and I are going to suggest we remove from our bylaws, because I'm sure that Dr. Duplantis has something else to do than go to these meetings unless there's a reason for him to be there.
And our medical director is at them, so there is a physician at our meeting.
Right, and that
already.
meets the legal requirements. I mean,
Yeah.
So I think we're going to want to change our bylaws, but our bylaws and the law does appear to require more than one.
Mm-hmm.
It says members plural, so that was one of my questions in terms of, about what the requirements are. That's why I was trying to make sure I was in the right place and that.
I will check into that, and I'll send you. I found a document that gives a nice overview of it. But it did not include that in there. So that might. I didn't see
And
that.
I'm looking
There's so
at
many
the
different
NYCRR
regs.
section. Yeah,
Yeah, there's so many
And the
different
mental
regulations
hygiene.
that impact it, and mine might just be a nice summary that does not include that particular piece. So if you share your information, I'll share what I have, and then hopefully
Okay.
we'll figure out the bylaw section. Okay.
Okay. All right. Well, thank you so much, Harmony. That was helpful. And I assume future reports will refer to those action steps and we'll get more detail about what's happened over the course of a year. Is that the format you're thinking? Great.
How frequently are reports sent to OMH?
So a report would go to OMH when, if you have a situation that you need a report, you have 24 hours to report it in. But you would report it when you have that incident. So if there were 20, then in 2020, there were 20 reports in 2020. So as soon as you're aware of the issue.
Okay, because there's also some report issues here that the regs, at least that I found, require being given to the CSB that go beyond, I think, an annual report. But I'll send you the section and
Okay.
then we can figure out.
Yeah, if we
what-
need to do it different, I think my understanding was there was an annual report required to the Community Services Board. But there may be particular incidents, types. So yeah, I'll read what you have.
Yeah.
Okay. Well, thanks a lot, Harmony, again, and it's very helpful. So going on to our next agenda item, I'm going to turn to Khaki. Khaki, Sheila, and I did a first look at the bylaws and came up with a list of things that we were interested in getting some input from all of you on. So I'll turn it over to you, Khaki, and I'll jump in if you need anything. So.
Okay. So we sent out a memo to all of you, and there are actually a couple of things I realized I forgot in my wanting to make sure that it got out with the board minutes. We've got, what is it, at 6:27? So we've got what, 15 minutes, maybe 10 minutes? How much time do you want?
We've got about 20 minutes would be
Okay.
good.
Which won't probably get us through all of it. So I want to suggest a few areas that we're holding, partly because of that training that we're going to have next month. That I think that in terms of the special review committee or incident review committee, a question that we raised in terms of membership on subcommittees from the board, and I left it off my memo, I apologize, but our bylaws, the county's charter, and the legislation all requires 3 board members to be on each subcommittee. What's not clear is that intended to be a minimum? Is that intended to be a set number? There can't be more, you know, what's the intent there? So that's one of the questions that I want to ask Jed, just to get some clarification on that. So is it okay for us to have more, you know, or what? There was one other, and we're going to want to have more conversation, obviously, about our relationship with the Board of Health. We raised a couple of issues there. We were attending each other's meetings there for a while we were in the process of deciding what the recommendations were going to be. We haven't continued that. But at some point we need to have conversation about what's the relationship between the two boards. The legislature may put specific language in their charter amendments, you know, which will drive what we need to have within our bylaws. But by the same token, we think we ought to have some conversation ourselves about what is it we'd like to see? What's the relationship we'd like to see? Do we want to go back to something like attending each other's meetings? Do we want to a requirement of an annual joint meeting or a semi-annual joint meeting? Is that the best way to go about it or whatever? So we'll hold those conversations until we have more time and or you know, some information from Jed next month. So we set out the bylaws as they exist, and then our comments are in italics and bulleted italics under each one of the sections. So I don't know how you want to do that. Should we just kind of go from the beginning and work our way through and see how far we get? Or are there particular areas that people want to jump in on, or what's the druthers of the group? Any druthers? Nobody cares about bylaws but Sheila and Mary and Khaki anyway.
I think starting at the beginning makes the most sense.
Okay. All right. The name, we get named here Tompkins County Mental Health Board, but it's actually the Mental Health Community Services Board. We missed that, but we ought to probably make that change. So anything in that paragraph on name that anybody noticed besides our name? Okay, purpose. One of the things, this is the first place that we see substance abuse and dependency showing up. We have shifted internally to using substance use and sort of making dependency implicit in that, and making it a term that's inclusive of alcoholism. All of the state legislation speaks of alcoholism and notes that we have the option of having an alcoholism and substance abuse board, subcommittee. I'll just throw out what makes sense maybe to me as we think about how we're going to amend our bylaws would be to use our preferred term of substance use and then define that, what we mean by that includes alcoholism and legal and illegal substance use, abuse, and or dependency. Does that make sense? And then we can just use our own language.
Yeah.
And that's good with you, Tom. I mean, I'm thinking particularly in terms of the, so we can adjust that in there. The other possible thing we may want to consider in that particular paragraph of purpose is that there are specific purposes for the board that are set out in the legislation, and particular purposes set out in the charter. And so it occurred to me, I mean, you can take the lawyer out of the courtroom, but they notice all these things, and that we may just want to add language that makes it inclusive of anything that gets later added into the charter or into the legislation, so that we don't have to amend our bylaws in order to match that. Make sense? Okay, so composition. This was one of the places that we found it was interesting. Our bylaws currently require that we have a licensed physician and a physician or a psychologist. The law actually requires that we have a physician and a psychologist, and if we can't get a psychologist, we are allowed to have a second physician. So our recommendation is that we amend our language to match what we're statutorily required to do. And, to be honest, we're not going to have, we have less trouble getting a psychologist than we do have getting a physician. It's, I don't think it's likely that we would never be able to get a psychologist. The conflict of interest. This is a new section we need to add. Our recollection was that we had agreed that that any employee of a funded agency could not be a member of the board itself or of a subcommittee, though they would be encouraged to attend subcommittee meetings and participate in that. Our first question is that everybody else's recollection, because it never really got codified in anything. That was, the first thing that we needed to And at least in terms of the board, we no longer have that issue on the board. And I don't think we do on the subcommittees anymore, right?
I
The
think
people
there's a
attend, they're not members.
right there. I think there's maybe one person whose term is ending. We had said that they could complete their term
Yeah.
if they were already in place.
And we'll want to double check that. And, you know, and I think it would be reasonable to include language that somebody can fill out a term. Has anybody had any second thoughts about that, reaching that sort of extreme on the conflict of interest? Because I know we had all kinds of other ideas that were floated around. Okay. Well, you guys are talking way too much on this stuff. Powers and duties, we just need to fix a section number. Term of office. Board of Health has limits on the number of consecutive terms someone can serve. Many other advisory groups do. Many not-for-profit boards do. We don't. We're not required by law to have that, but Sheila and Mary and I thought we should at least raise the issue for discussion if the board wanted to have a conversation about that, or if anyone thought we should be considering such a thing. This is where you jump in.
Well, so Kaki, this is Elise. My thought on that is that with the restrictions on not being able to find to include folks from funded agencies, I think it's very difficult to find others that are interested that are not, you know, that don't do this work for a living and that aren't part of those funded agencies. So where I see it would make sense to have term limits in one way. On the other hand, I feel like if you have active, engaged members and then you might struggle to replace them, it's hard to justify.
Others?
I think that's true as well. I'm thinking of just the historical piece that so many people, and myself included, carry with them that gets lost when you do a 2-year rotation. I mean, sometimes people aren't even sure what they're there to do for the first couple of years.
Oh, yeah. And I know, I mean, like family and children's, I think you can serve 12 years and then you have to step off. I mean, it would need, you know, and it's rotating board members so that because you're right, Jan. We don't want to lose the longevity or just, oh, you're out of here after 2 years. Well, first of all, we'd never have a chair.
Well,
And
it's
how many
probably-
terms? So how many terms can Board of Health people serve? Consecutive terms, Frank. So they have 6-year terms.
2. I don't know why I'm typing. I can just
Oh,
Yeah.
okay.
Yeah, the Board of Health terms are for 6 years. They can do 2 consecutive terms unless and anything beyond that, the legislature has to approve. And that happens pretty frequently. So if we have strong board members and they've done their 2 terms, if they're interested in being reappointed, if the board so chooses to renominate them, the legislature can reappoint them again. They just have to do it with a special action to give them an extension.
Larry.
I probably have a conflict of interest since I've been on the board since 1992.
Well, it's uncomfortable for us to even raise it because it's certainly not focused at any person. We're just
No, but what I
going
was
through the.
what I was going to say, I don't think we've had problems replacing people when people move off the board or resign. So I don't think not having term limits affects the ability to bring new blood into the conversation, so to speak. I hate that term, but it's the one that came to me. And I don't really understand what the purpose of term limits is if there's not there are other ways to deal with people who are, behaving badly on a board.
Well, and I don't think there's an assumption of behaving badly to drive term limits
No, I'm just-
necessarily, that it's.
Right.
No.
I'm just
Question
trying to
is
say,
it healthy? Let's say everybody on this board had been on it since 1992. That's not likely to happen, but
right.
the question becomes, is that healthy and is that the situation for the community?
That was my first point. I don't think we've experienced that. I think there's been a lot of turnover and people coming in and out.
So
Yeah.
it sounds to me, yeah,
I-
Mary.
I wonder if this is one of those pieces that we might need to revisit. Maybe people think on it a little bit, or, I'm hearing the sentiment is maybe not do term limits, but, I just wonder if it might be worth revisiting this is going to take a long time to revise these bylaws, and there may be a couple of areas people want a little more thought on.
I think that makes sense. We could also, I mean, most of us are probably on other boards, and I think it would be helpful to just kind of get the temperature of how do most boards, or how do the boards we serve on or are associated with, how do they handle it?
Mhm. And it is a discussion that's hard not to be personal. Yeah, it's like, oh, I don't want-
Larry, no.
No, I think of myself, and
Yeah.
you know,
Yeah.
yeah, so it's just one of those things that I think, Jan, that's a good point, to kind of familiarize ourselves with the way other boards do this and what the value has been to them to have a structure like that.
Yeah, it's an interesting balance, because while you want people with some history, you also, I think there's also the argument to be made about fresh perspectives and new ideas.
Mhm.
So it's kind of, it's hard to say which is advisable or whatever.
Okay, so to be continued. We didn't have any comments under vacancies, resignations, or termination. Oh, yeah, under termination, we were trying to replace all gender-specific language with gender non-specific language. There's only a couple of places that happens. In terms of termination, when it talks about somebody being granted a leave of absence, if they're needing to miss that more than 3 meetings in a year, just raising the question of, do we want to set a limit on what the length of that leave of absence can be? Say you can have a leave of 6 months and it could be extended or whatever. Again, just tossing out the question. Or do we just leave that up to the chair
I think it's better.
and assume that they wouldn't grant a year-long or 2-year-long?
It seems like
Maria.
it's almost better to have a rule than to leave it to the chair. Because then that puts the chair in kind of an awkward position. Or maybe not. I
Maria?
don't know.
I do
Maria?
see Jan's point. It can put the chair in an awkward position, but I also think that varies depending on individual circumstances. And I'd want to leave us enough flexibility that, if someone should have an illness, for example, and need an 8-month leave of absence, but still is very committed to the board and the functioning of the committees, I would hate to see that there was a 6-month limit. I would like to see something that would leave us flexibility, is what I'm saying, if in fact we would add a limit.
In my mind, one of the questions is what's the outside limit? Because if we said 6 months and it could be extended for another 6 months, that really makes it a year outside limit. At what point is someone out too long from the board? I mean, we wouldn't want someone to give somebody a 2-year probably leave or something.
The
It's just
bylaws
something that,
do require a 2/3 vote of the board, right, Khaki, in order to recommend termination?
to
So
recommend termination, yeah. But the chair has the right to give a leave of absence, so that you're not chalking up more absences, and invoking that 2/3 vote.
yeah, I guess my point being is that a 2/3 vote is a pretty substantial thing, and it would take quite a bit to rise to that level. So if the majority of the board felt it was a reasonable absence, there is a checks and balance to the chair, I guess was my point.
Although I guess I would ask, how would that work? I mean, let's assume that you had a chair that granted a leave of absence to someone, and they're the only ones, and they have the power to do that under the current bylaws. But the rest of the board felt that that was unreasonable, then don't we need a mechanism for the board to be able to raise the issue?
Yeah,
Paula?
I was reading it that with a 2/3 vote, you could override whatever the chair did, but it doesn't actually say that. You're right.
What if the chair can give a 6-month absence leave without consulting, without permission from the board, but anything beyond that has to be decided by the board
I like
by a
that.
2/3 vote, or whatever.
Or even a majority, I mean.
Or a
would
majority,
be okay with me.
but somehow the board, if it's more than 6 months, the board has to be involved in granting that. It's just an idea.
I like that idea.
Yeah.
Okay, we'll let that rest for now. As Mary said, this is going to be a lengthy process. We're not making decisions tonight. Are we run up on your time, Mary?
Yeah, I
So-
think this might be a good place to end.
Okay,
All right, so
thank you. We'll come back to this.
yeah, thank you so much. And I assume we'll pick it up in November. I think October is going to be all training. So we'll continue then. And as you said, Khaki, there'll be information from that training that we'll want to incorporate in some way too. Great. Well,
As well, I'll be interested, I don't know, Frank, that the Board of Health has had any conversation about this, but it would be useful for perhaps them to also have some conversation about what the relationship is they'd like to have. I would think the legislature is going to want to know from us all. I would hope.
Yeah, I think the Board of Health probably could go through a bylaw review as well. And I think likely you'll want to align wherever possible on things just to try to be consistent. I am of the opinion that both boards should continue at least for a few years post as separate boards post merger as a checks and balance. So I'm certainly not proposing any dramatic merging of the two boards together, at least initially. But I think we definitely, while we're reviewing, if there's ways to provide consistency between the two, it seems like that would make some sense.
yeah. And I think we talked during the merger discussions that, we wanted to be modeling that kind of collaboration the way, the way we're asking staff to do that too. So that would be a good time. Okay, so we're on our last item here. Is that you, Harmony, about this RFP? Or Frank?
Yeah, Harmony, I'll give you the update.
Okay, I'm going to try for the first time. So Larry said that he was able to admit people on Zoom for the first time and successful. I am going to hope for successful small video, 3 minutes.
Oh my God.
I have no idea. We'll see how it goes.
You're
Fran
brave.
may need to come in and help me.
You're
get
doing that in
it
person.
time. And basically, the person wants to.
Show it
open
on
up-
your screen and then share the screen.
Oh, where'd my share screen go? There it goes.
Sound would be good.
Can you hear it?
No,
No,
Okay, it was so much louder when I practiced. And I'm trying to find volume. No,
it's the little speaker guy there on the left.
it just looks like that's mute and unmute, and he doesn't get louder. It was really loud before. So maybe I will.
Put the closed captions on.
yeah, that's what I was thinking.
Captions on.
Oh, hit close.
CC down at the bottom. On the right,
Okay.
and hope that they're open. I mean, maybe it won't help us.
Let me go back here. Are you seeing it at least?
Yeah.
Or now I see a volume thing.
Stop it.
Uh-oh.
That's the one. You know how your volume is over there?
So I know who the outpatient providers are. I know who the nursing staff is. The relationship with Tracy is really all over.
You see it?
I have no idea what they're talking about.
Yeah, Harmony, why don't we send a link to the video out to folks and just talk them through right now? But you put yourself on mute.
Okay, Corinne was trying to help me, so I was trying to mute myself, but we'll give up. Okay, so I didn't have the success that Larry had, but basically I will send you this link. Please watch it. It is about a pharmacy called Genoa Pharmacy. The reason I was showing you that link was because we are considering the possibility of providing a pharmacy right in the mental health department. So Genoa Pharmacy has 15 pharmacies so far in New York State. They're a company out of Washington State, outside of Seattle, and they're a specialty pharmacy. And what they do is they provide services to the clients of the clinic or a PROS program, to their families. They could even provide pharmacy services to the staff here, which is a nice perk. Now, what we're looking at is the potential of having this go up for an RFP. So they're only one potential provider, but I wanted to give them to you as an example. They are located in Auburn. They have one in Albany. So we have been able to go and visit the site in Auburn and try and get a sense of them. But there are other specialty clinics, pharmacies like them. And the benefit of having a pharmacy located co-located in our building for our clients is that they specialize in helping support people with mental illness, especially people who have serious mental illness, who are really struggling with taking their medications. They have special packaging so that they're right here in the building. When people come for their appointments, they can provide a lot of consultation. You know, sometimes you go to the pharmacy, there's a lot of people around you. It's very quick. It kind of feels impersonal. They really try to be very personalized, and they really, their mission is to help people take their medications regularly, because they know that that's going to result in better health outcomes, less emergencies, and that sort of thing. What they would do is potentially rent space and have their own separate pharmacy, but they can also coordinate services, sort of like what we do in schools now, where if a child's getting services in a school district and with the appropriate release, you can talk about how that child's doing in other places. And it's just more, collaborative of a service. So if someone's not taking their medications regularly, they can troubleshoot. They could be a part of your multidisciplinary team meeting. They can help, support people, and they're going to notice somebody's not taking their medications a lot sooner. It would also free up some of our medical staff who spend an inordinate amount of time right now in what's called the script line, getting prescriptions filled. You cannot tell somebody, well, if you're going to the clinic, you have to use this pharmacy. People can choose to use whatever pharmacy they want. But the hope is that they see a lot of benefit of having their pharmacy located right here, so that they can get the support they need, and special packaging or consultation, whatever kind of help. So that is my bungled pitch for a pharmacy. We will, and that is just one organization, but we're really excited about this. We think it's really going to improve the quality of services for the clients that we have. They used to go to the pharmacy right next door to our building. That has since closed. That was very nice because it was right nearby. It was very personalized. It wasn't like one of those larger sort of pharmacy operations where you're surrounded maybe about a lot of noise and a lot of crowd and a lot of people. So we think it could be really helpful for our clients. And the testimonials we heard when we went and visited in Auburn, I mean, it was incredible. The staff there said it's really made a huge difference for their clients, in terms of, someone's calling them regularly and say, hey, how's it going? Are you taking your meds? Is everything working out okay? And they know everybody by their name. It's kind of like that old fashioned pharmacy model that people don't get very much. They also will mail your meds like other pharmacies. They can also support other agencies. So if like the community residents in our community wanted someone else to do pharmacy for them, they could drop off their medications like on a weekly basis for them. So they can be a support to other mental health programs or substance use programs in our community. Any thoughts or questions on that? Khaki?
Would they be a full range pharmacy and be able to do vaccines and other drugs that were perhaps? Okay, cool.
Yeah, they could do flu vaccines. They do, when we were visiting, they had signage up for people in the bathrooms. If you want to get your flu vaccine, come here. Other kinds of, other kinds of vaccines and other like preventive healthcare or any other kind of medications people might need. It's not just restricted to psychotropics. Larry, you're on mute.
The one question I have right off the bat is a philosophical one, which has to do with, I assume this is I assume this is a for-profit business.
That's a good question. I'm not sure. This one, Geno in particular, the person who started, his brother was diagnosed with schizophrenia, and he was just really unhappy about the quality of pharmaceutical care his brother got. So it's a very mission driven. But I'm not sure if it's a nonprofit. I do know that they focus on Medicaid, Medicare, and people who have no insurance. So they try, they're trying to really support that population, but I don't know if they're a nonprofit. I can look into that.
Yeah, so I think that would, I mean, I'm not reflexively opposed to that, but I think it's a thing to have a conversation about, since we're a county agency. what does that mean? I mean, we refer to other kinds of for-profit entities. I mean, Wegmans is a for-profit corporation, and I'm sure a large number of our clients go to Wegmans, but it's Wegmans isn't in our building. It's
That's
basically,
partially why we have to do an RFP for
Yeah.
this, is to get answers to some of those questions and make sure that if we do allow someone to come into our building, that we're getting the best deal possible for the county and the people we serve.
I looked it up. They're a nonprofit.
okay. I just think it's
Well, the Genoa Foundation is a nonprofit.
the pharmacy may not.
And they say, what type of pharmacy? It looks like they are a foundation, but I'll do some more research.
In any case, I just think even if we got, I mean, there could be a completely cool for-profit organization that we decided to go with if we decided. I just think we have to have a conversation about how that would work. The other thing is just safety. I mean, you know, having a range of prescribed drugs in the building. I mean, I assume we have them in the building now, but having a pharmacy in the building, especially since the building isn't open for significant parts of the day, might be a problem.
And that was our biggest concern too. So that when we went and looked at another site, Safe there, they come out and look at your building to figure out how best to create a safe pharmacy that can eliminate, well, can reduce the risk of any medications getting stolen and that sort of thing. Or so they have protocols in place to maintain the safety of the pharmacy and how they build it out. Also, there's no signage outside to advertise that there's a clinic. So it's really, although technically it's a public pharmacy, but nobody's going to really know it's a pharmacy inside your building unless they come into your building. But they think about they have a lot of regulation, I guess, in pharmacies about how they have to build to make sure that everything's locked up and secured, and they have cameras around that section. And typically the hours of operation where people could come in and get medications would be limited to when we have hours of operation. Their staff could come in and maybe do work in the pharmacy, just them, but it wouldn't be open to the public except when we're open to the public.
Maria, you have a.
As a county agency, would we limit it only to people who are receiving services from the mental health clinic? Or would it be available to anyone in the county, since it's a county building and a county supported service?
I think it's available to anyone in the county. However, there's no like advertising that they do outside of the building. What they do in some of the pharmacies is you might have another clinic in town who's serving a lot of people who they could actually help support their medication needs as well, by, you know, boxing things up and taking them over and that sort of thing. So they can support other programs in your community. Even if the traffic isn't coming through your building, if they're doing medications in their building already, they might be a better, more affordable provider of medications.
I'm also wondering about like neighbors. Could people who live in the neighborhood use that pharmacy, since they are, you know, they live in the county and they would, pardon me, the county provide, you know, they pay county taxes. So I guess that would be my question. Would that be open to people who wanted to get their Lipitor because it was prescribed by their local doctor and it happened to be within walking distance of where they live, and they just chose that as their pharmacy instead of going, for example, to Wegmans?
Yeah, my understanding is they can use the pharmacy, but they're not doing a lot of promotional out to the public in general. Because it's going to be somewhere in our building too, right? So there's not like a heck of a lot of figuring out how to have a pharmacy that can support the needs this, you know, like the specialty pharmacy needs of the people you're serving.
And there are also confidentiality issues about, do we want the general public to feel like they can wander over to the mental health building pharmacy and get their medications and see people who are walking in and out of the building? I mean, people could do that anyway, but do we want to give that kind of reasons for people to be in the building? I mean, this is all this, like Frank said, this is the stuff around what the RFP would look like. So.
Yeah, that's sort of, I agree with Larry. I was kind of thinking of the logistics of having a county supported program in a county building that's also providing confidential services, and how we would structure that and protect
Yeah, I think-
everyone and make services accessible and available as well to everyone in the county who might be eligible for them.
Yeah, I think part of it is we wouldn't be running the program, right? We would essentially just be leasing space in the building, similar to how we lease space to the Alcohol and Drug Council. And that organization makes its own rules about who they serve and when they serve them, right? Obviously, they serve the public too, to a degree, but we don't control who they bring into the building or don't. So there's a mixture here. And that's what we're trying to kind of figure out. I think the RFP is going to be a component. We've heard from Genoa. We know there's other entities out there, so we're hopeful through that process we'll learn more about what options are out there and how other people would propose to do it, so we can pick what's best. The Green Street Pharmacy closing was a big hit to our population, and so we would never have thought of doing this if they were still open. Because first we want to support a local business, but two, it was working. We had a great relationship with them, but because that's no longer available, the staff felt like this was the time to start looking at, if there was an alternative way to help support folks. But yeah, all good points you're bringing up that we'd have to work through.
Well, that raises another issue, which is it really that we want a pharmacy close by, or is it that we want to improve what people experience at other pharmacies? And is this a chance to do stuff like mental health 101 or all that kind of stuff? I mean, what is our relationship with the pharmacies that are prescribing? Is it good? Is it bad? I mean, I agree that having a pharmacy close by made sense. And I heard that people liked having that because you could walk over there and talk to the pharmacist. But are we solving something that's not really a problem?
I think, Larry, what's unique about this is that you can have good communication with all the pharmacies in town, but they're not specializing in people with mental health needs who maybe are on injectables or taking up to 15 different pills. And they really focus on people who have a severity of need. And they help look at medication adherence, and they have demonstrated, they help give you reports so you know how well your clients you're serving are doing. They're like a partner more.
So it's not like Frank suggested, we're not just leasing the space. We're looking at, because they would be in our building, have a more direct relationship with them.
Mm-hmm. They're still leasing, so they're going to have their rules and their own things, but they would be partnering with you in a way because of that location. They're going to partner with you in a way that you're not going to get. And they have specialized knowledge in working with people with serious mental illness. That's their focus of their services. They're not trying to be the Wegmans. They're not trying to be Walgreens. They want to be the specialty mental health pharmacy that also happens to give out flu shots. But their focus is really on supporting people. They have special packaging that they help with people.
Well,
so
this particular entity,
one, but I would assume that that's similar to other specialty pharmacies. And I'll send you a couple other clips that you can watch. They kind of give you a nice overview of like what it's like for a client who maybe really struggles with medication adherence, and having a pharmacist who knows about their struggles and more personalized relationship can give that extra support to help with compliance around their medications. So it is a little bit of a different model, and it really started out of a desire to improve the quality of pharmacy services people with mental illness can receive by linking it right with their treatment providers. But they are their own, like, we don't have to worry about, you know, their financial situation, and that's like they're their own business.
Well, so it sounds like we'll be hearing more about this process then, and I'm just aware of our time and should be wrapping up here, but we'll be hearing more, Harmony, I assume, as the RFP gets created, and we'll see what happens there. Oops, sorry. All right, so thinking we should wrap up then. Any final comments? Anything else? All right. Can I have a motion to adjourn? Dr. Dupont, and a second, Maria. Okay. Thanks, everybody. And next month we'll be meeting on, I think it's October 4th. Is that correct? And
Yes.
and then we'll be spending the full meeting on the training that Harmony's arranged. And that'll be great to all hear that together and have any questions we have answered at that time. All right. Well, thanks everyone for all your questions. It was a packed meeting. A lot happened. So
Thank
have a
you.
good
Good
month.
night.
Bye.
Bye.